Catheters. Anybody ever get any queries about catheters? Yes, I thought you might do. So I've got two little things here. Blockages. How do you deal with the dreaded recurrent blockage of catheter, apart from sending the patient to me? Any suggestions?
District nurse for washout.
Right, step one, ask if the patient can have a flip flow valve. See those little things like a tap, just a little tap goes on the catheter. Get it opened and closed intermittently. Often the patient or a carer or something can do that. The urine stores up, you open it, it all whooshes out, takes the debris out. Brilliant way ahead. Nice and cheap, doesn't involve a moaning district nurse. All right, that's all very good. And they've got plenty to do, let's face it. So, that's step one, flip flow valve. Step two is bladder washout. How often? So you can probably start off at once a week, so as not to cause extreme mutiny. But in fact, you might have to go as often as daily bladder washouts if they produce a lot of debris. Some people who put catheters in their bladders and their bladders don't turn a hair. Other people get a big reaction against the catheter, produce loads of debris. And it's the debris rolling around in the bottom, forms sludge and blocks the catheter. Occasionally, if you've done all of that, you know, flip flow valve, bladder washouts on a daily basis, not working, given up, send them to us, we'll do a bladder washout, put a flexible cystoscope in, swish it all in and out, or a GA cystoscopy if we can, and that'll be beneficial for a bit.
Can you just put a bigger tube in so it doesn't get blocked?
Then you tend to get more in the way of penile erosion. So you might have seen those chaps that the catheter's eroded through the base of the penis and it starts to look like a kipper. The bigger the catheter is, the more likely that is.
You know, I mean, if you're going from like a 12 to a 14.
That's all right, that's not too mean. But if you're going for like the 22 vicious one, then I think that's probably
Where's the valve?
So the flip flow is, you've got catheter here with the catheter end there, and the flip flow fits in, and then on the actual flip flow itself, it's got a two-way tap. That position is open and that position is closed. So it goes on the outside of the catheter. So they can still have a bag fitted if they want. They can wander off to the loo, but they can still have a bag fitted. You can leave it open at night for the night bag. You know, if they're on normally continuous drainage because they're not fit enough for anything else. But during the day, if they've got a carer that comes in, or they've got a carer in, or they're in a residential home or nursing home or something, I'd just put it open and closed throughout the day, and it'll help stop blockages.
Who does the washouts?
District nurse normally, but sometimes at the hospital, if they've got a nice carer or a relative or something, we'll teach them how to do it. It's quite a simple thing, and I think if they're happy, if the patient and carer's happy, then I think it's reasonable.
Who fits the valves in? Who fits the valves in?
District nurse will fit a valve, yeah. And the district nurses might believe in various clever chemicals, Subi-G and all the rest of it. I don't think there's very strong evidence that any of them make any difference. Tap water's fine.
There's some silver-topped catheters.
Silver-tipped catheters, yeah, maybe. Expensive, aren't they? I'm a platinum man myself. Is that all right? Yeah.
Or sometimes when they, after catheterization, or even there is stable, still is bleeding. Yes. So what you do with that?
If you put a catheter in, they bleed.
No, after they will bleed definitely a little bit, but later on, after a few days, after 2-3 days,
I think if they've got really persistent bleeding, we should probably review them. Shouldn't they? Should have a cystoscopy. And the other problem that you get, if you've got patients that got catheters in, and in the long term, or people were doing ISC in the long term, and they start to get blood and they didn't have it before, and they've not got a raging UTI, you treat the UTI and the blood comes back, again, be a bit nervous. I'd rather look in their bladder because, you know, we always think of transitional cell carcinoma for bladder cancer, but actually people can get squamous cancer and it's caused by chronic irritation. So a long-term catheter, recurrent UTIs, that can cause it. So just be a little wary. Suprapubic catheters often get letters where it'll say, please see this patient struggling with blockages, could you consider, would a suprapubic be a good idea? I don't think it really is, to be honest. It goes in a different route, but it just sits into the same puddle of junk. When it blocks and it gets taken out or falls out, it's not very easy to put it back in again. District nurses don't really like doing suprapubics in my experience, so I think it adds a whole load of complication. The time where it is good are ladies with MS, because what you find with the ladies with MS, they have hypertonic bladders, overactive, they start to extrude catheters, even with a balloon blown up. They'll do much better with a suprapubic. So that for an MS patient, they're probably pretty good.